Good day to everybody. Thank you for joining Cadwell for this third webinar series on EEG trending. Today, we've got Anita Kharbteng on call doing this presentation. She's a very experienced physician, lots of clinical experience in EEG, ICU, and we're excited to have her. Just a few housekeeping notes. This session is being recorded and it will be made available after the webinar, and you can find those webinar recordings at cadwell.com/webinars. All attendees are muted and in listen-only mode. We have all webcams turned off. We welcome all questions, and you can use the questions pane in your control panel on the GoToWebinar control panel. We are going to hold all questions to be answered until the end. We will be having some poll questions going on throughout the webinar as well for your participation, and we'll let you know when those are starting. Asset education credits have been approved for this session for those people that are attending the session live. If you have an asset ID number and would like to have it recorded with the roster sheet, please email workshops@cadwell.com with your name and your asset ID number. You do not have to have an asset ID number to get credits, however. I think with that being said, we will turn it over to Anita. And again, thank you all for joining.
Okay. Good morning, good afternoon, good evening. I don't know where everyone is, but I'm in Singapore and it is midnight for me. So the typical Asian greeting, good morning, good afternoon, good evening. So I'll turn off my video cam. I just wanted to say hello with the video on. I don't want the video to interrupt with my presentation. So just a short introduction. I graduated from Lady Hardinge Medical College, New Delhi, India. I've been in the neurophysiology device business for 20 years, and I'm a strong advocate for monitoring and caring for the brain for improved patient management and neurological outcomes in the Asia Pacific region. So I would like to know you. So this is a poll question, Laurie. If you can answer this, so I get to know my audience here. So we have so far a majority technicians, EEG technicians. Wonderful. Some physicians and others. Okay, thank you. So welcome everyone for this webinar. I'm so glad that you're interested in this topic. While making this presentation, I decided to deviate from the topic a little bit to give you more of a background of the challenges that I faced in performing continuous EEG of critical care patients in Asia, and my journey or experience in bringing this continuous EEG into the ICU in Asia. I will share some of the clinical trends that we are using in the ICU, first in the neonatal and then in the adult ICU, and I will focus mainly on the AEG, but I will also show other trends, and then I will conclude on the Asian experience with the trending for critical care patients. So the reason I started in this field is because of this presentation that I saw nearly 20 years ago by Dr. Sansa Vanhapalo from Finland. He's a pediatric neurologist, and he showed this slide and he says, why is it so important to do continuous EEG monitoring in the neonatal ICU? And he says that there is a really high prevalence of neurological complications in the neonates, especially in the first few hours and first few days of the neonate's life. And it still is very common and unacceptable costs to the child, the family, and society. And then he showed this next slide. He says, imagine a pregnant woman giving birth, and the baby has to be taken to the ICU. And EEG monitoring could actually make a difference in the outcome. And this picture stuck in my brain for a very long time. It made a big impression. Another presentation I saw from Dr. Paul Vespa from UCLA, and he showed this patient lying surrounded with all this, so many equipment in the ICU, and this caption which says, with all this fancy technology, I hope someone is monitoring my brain. So this picture also made a big impact on me. And when you think about it, why is continuous EEG so important, especially for critical care patients? Because most of these patients are heavily sedated, they're placed in medical coma or medically paralyzed, and EEG is the only way to see what is going on in the brain. And you know that the sick brain is very vulnerable to seizures and hypoxia. So why do we do continuous EEG? It helps to make the ICU clinician very quick and accurate clinical decisions on how to manage their patients. It helps them to monitor the benefit or harm of all the treatment that they're giving in the ICU. How is it working on the brain? To prevent neurological complications or even death, and for prediction of outcomes, because this is so important. It helps the clinicians make decision on patient management and what do you communicate with the family. So with this importance, I was wondering, why is continuous EEG so rarely done in the ICU or emergency department in Asia? How do we look into the brain of these critical patients who need it the most? So I went around the different ICUs in Asia, and this is what I found when I asked the intensivists why. And I was quite surprised that most of them were very interested, and they all wanted continuous EEG, but they had no EEG knowledge. Most ICUs do not have EEG systems, and very few neurology expertise. So when they put in a request for EEG, the response time from request to interpretation was too long. And in many hospitals, they don't even have this service. So when I asked the neurology department, they said, well, we would love to do it, but we don't have enough EEG machines nor technicians to be able to take all the ICU requests. And then if you're going to do very long monitoring, who's going to maintain those EEG electrodes? And as you know, EEG has so much data. Who is going to read all of that? And who's going to be monitoring and interpreting the EEG real time? When it comes to neonatal EEG, there are not very many pediatric neurologists in each country in Asia. And you know that interpretation of neonatal EEG is very difficult as the brain changes with gestational age, activity state, and medication, even in normal neonates. Forget about the sick ones. So these were all the challenges that I encountered. So my poll question again, I want to understand how many of you actually perform neonatal EEG. Laurie, you can bring up the poll. Do you do it? Yes or no? Oh, quite a few. Wonderful. So majority perform neonatal EEG according to the poll. Excellent. So I'm speaking to a very expert audience then. Do you perform continuous EEG on all ICU patients? Next poll, Laurie. Yes, no. So majority is no, but I guess you do on some. All right. Thank you. Next question. How long do you monitor ICU patients? Laurie, sorry, next poll.
Anita, I'm not seeing that poll question in the list.
Oh, I see.
The next pattern is, or the next question is, what is the pattern?
Oh, okay. I'm so sorry. So if some of you can just write so we can see how many hours.
Yeah, we could answer the question and answer this poll question in the question pane, if you wouldn't mind, attendees.
Yeah, sorry about that.
Oh, I see one person is 1 hour. We've got 12 hours.
At least 24 hours.
Yeah, you can see that. Okay.
Yeah, 24 to 48. Oh, awesome. So I'm so pleased to see this. We have a good group here. Okay, thank you. So let me share my journey into the neonatal ICU. It was a long journey with a lot of tears, but a lot of joy as well. So I first started by going to Europe because we heard of the CFM monitor developed in the UK by Pamela Pryor and Douglas Maynard. It's also called the AEG, or Amplitude Integrated EEG device. It was developed for adult patients, but the neonatal ICU in Lund used this device and in the 80s, and they found that it was really very useful even for neonates. They found a lot of very interesting patterns, and so they published the Atlas of Amplitude Integrated EEG for the newborn, and it became a standard of care in the neonatal ICU in most of Western Europe. And by the late 90s, there were better EEG systems with AEG that were developed for this use. So I learned a lot from my mentors in Europe, from Sweden, Finland, Geraldine Boylan and Cork. So I took this knowledge back to Asia, and I started with Japan because Japan has the highest number of pediatric neurologists. They do a lot of good clinical work, highly regarded worldwide. Clinical trials started in 2006, and by 2008, AEG technology became a standard of care for HIE in the NICU. And today, all NICUs in Japan are using AEG. I next went to China because it is the biggest market in Asia, and some NICUs have up to 150 beds, and also very eager neonatologists wanting to monitor the brain. So our first CFM meeting was in 2012. The Atlas of AEG was translated to Chinese, and today most of the major NICUs in China are also performing AEG. And then we took this technology to the rest of Asia, sometimes with success, sometimes not, but majority of the big NICUs in Asia are doing AEG. But still, we have many challenges, and there's still a lot of work to be done in this field. So we followed the practice in Lund Hospital, and what they did was during green hours, acute EEG was done by the neurology department. They put on their 1020 electrodes, and then later they would monitor, they would tailor their monitoring depending on the patient. During red hours, it was the neonatal department, so nurses or neonatologists who put on the electrodes depending on they would either use one channel, that's C3 to C4, or four channels, F3 to P3, F4 to P4. And some use stick-on electrodes or cup electrodes, and some use subdermal needle electrodes because these were so much easier to apply, no prepping, and they would last for days and no discomfort for the baby. And then neurology would come in when they had the time and do a full EEG, and then again decide how to tailor the monitoring, because if they are going to monitor for many days, it will be hard to maintain too many electrodes. And then, of course, the interpretation was done by AEG and EEG. So let me revise again. What is AEG? It's really taking the EEG signal and asymmetrically filtering it at 2 to 15 hertz. And you want to remove the low frequency activity like movement and breathing, and the high frequency activity like muscle activity. You also want to amplify the 2 to 15 hertz activity. And then you plot this on a logarithmic, semi-logarithmic scale, meaning this is 0, this is 100, and the half is 10 and not 50, because they want to amplify the low amplitude activity. And then you compress the time scale at 6 centimeters per hour, which is about 4 hours on the screen. So a quick run through of what it is. So this is not really very accurate, but this is a nice description to make you understand. So if you can imagine, this is your 10 seconds of EEG. You filter it at 2 to 15 hertz to remove the noisy frequencies, and then you put it on a semi-logarithmic scale. You rectify the signal, you smooth it to identify the minimum and maximum peaks, and then you start compacting it at 6 centimeters per hour. So compact, 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 compact. And that's your AEG. So for the EEG experts here, they will say, what is this? But over time, it builds up a pattern, and this pattern will give you a lot of information on the brain. So it gives you information on the background pattern, seizures, burst suppression, and sleep-wake cycling. So these are the patterns, and there are two types of classification. In the earlier days, it was depending on voltage, but now most people have gone with the pattern classification, which is by Lena Hellstrom-Westers, Ingmar Rossen, and Linda de Vries. So the best pattern to have, of course, is the continuous normal voltage pattern, which is the normal pattern. So you can see that most of the tracing is between 25 to 50 microvolts, and it's compact. And then when the baby is asleep, you can see it broadens. And then when it's active sleep, again, it becomes narrow. So when you see this sort of sleep-wake cycling, you know this is an active, healthy brain, good outcome. This is a discontinuous normal voltage pattern. You can see the lower border, it's somewhere around 5 microvolts. It varies, goes up and down. And then the upper border is quite high, around 50 microvolts. This is a burst suppression pattern where the lower border is kind of straight and low, usually hitting the 0 line. And then the upper border is also very high, 100 microvolts and above. So that's burst suppression. Low voltage, you see most of the pattern is around the 5 microvolt area. And flat isoelectric. So these are the traces you would say they are normal trace, and these you would say are abnormal traces. So I will test you on these patterns later. And these are the different patterns on different gestational age, and you can see at 23 weeks, so young, and This is the kind of pattern that you see. Again, discontinuous, and this is 26 weeks. 30 weeks, you can start seeing some sort of cycling. And at 34 weeks, it's getting narrower, and then the very obvious broad area when they're sleeping. And then at 40 weeks, you can see it's nice and narrow here, and then when they're sleeping, active sleep, deep sleep, quiet sleep. So when you look at these patterns, you know if the baby is developing at the correct gestational age or not. I mean, if their brain is developing at the correct gestational age. To look at higher than 40 weeks, there is a group in China that has done a lot of studies for babies up to 3.5 months of age, and they have these patterns for older babies. I'll just give you some examples of clinical applications in the neonates. The most important one, of course, is using AEG for HIE babies undergoing hypothermia therapy. And this is the main reason why AEG really took off. It's because there was a therapy involved with it. You could actually do something to improve patient care. So as you know, HIE is still a major cause of mortality and neurologic morbidity worldwide. And therapeutic hypothermia is a standard of treatment for HIE. So you will lower the baby's temperature for up to 72 hours to help slow down the injury process in the brain. So the time to start this hypothermia is within 2 to 6 hours. So you have a very small window since the birth of the baby. So you have to react within that time to start the therapy. And as you know that cooling these babies have serious side effects as well. So you want to enroll only babies that would benefit from this. So AEG is a very user-friendly technique based on pattern recognition or amplitudes to identify these high-risk infants. So again, you would use this classification. Some will use voltage, some use pattern. And so when you monitor the infant, if you see this pattern, you know this is a good, healthy brain. So this baby will not need cooling because the brain is good anyway. If you see this pattern, some will decide, yeah, it's discontinuous. Some will say it's moderately abnormal and this baby will benefit from cooling. Some will say no, not. Burst suppression, again, they may say these are the two patterns that really will benefit from the cooling. And then low voltage and flat, maybe it's better not to cool these babies because they have a very low chance of a good outcome, even with cooling. But again, every institution is different. They have different criteria. Some will say we'll just cool them anyways. And of course, you have to inform the family and you get consent. And in the end, it's the family's decision as well. But again, at least you have a pattern, that a criteria that helps you select. And during the cooling, you will monitor the baby continuously, 72 hours. And then when you bring them to normothermia, you have to continue monitoring because now you have to watch the AEG tracing. If it comes back to continuous normal voltage within 48 hours, you know this child has a good chance of a good outcome. And you look for the sleep-wake cycling as well. If it comes within 36 hours after cooling, you know that they have a good outcome. And again, these seizures are non-convulsive, obviously, because the babies are sedated and under relaxants because of the cooling. So the only way to detect seizures is by the EEG. So they're detected and treated. And again, the decision to withdraw care is if you see a persistent abnormal background pattern at 48 hours. So AEG has become really useful for this HIE babies for their treatment. And making decisions on their patient care. The next clinical application is prediction of outcome, as we've been talking anyway. So some examples again with HIE, like we mentioned, even if you're not cooling, you can just monitor to prognosticate. So if you see these patterns, of course, you know they have good outcomes. But if you see these abnormal patterns, again, if these patterns don't recover within 24 hours, they have a poor outcome. But if they do actually recover within 12 to 24 hours, there's a chance of a good outcome. So for example, there's a 50 chance of a good outcome if a burst suppression pattern becomes continuous normal voltage within 24 hours. So if you look at this baby here with hypoxic ischemic encephalopathy, grade 2, you can see this is a burst suppression pattern, and also there is some seizures. So treatment has been given, and you can see the pattern. Now this is 9 hours, starting to improve, becoming discontinuous. At 14 hours, it's starting to become continuous, and there's actually some sort of cycling as well. So you can see it has come back to continuous normal voltage pattern. So you know that there's a 50% chance of this baby surviving without any handicap. So it is really very important to monitor asphyxiated infants with an early burst suppression pattern for at least 24 hours. And if you look at the sleep-wake cycling, again, if they return before 36 hours, and this is a sign of a good outcome. Love to see this pattern. But if you don't see this pattern within 36 hours, then it is a sign of a poor outcome. In preterm infants with intraventricular hemorrhage, grade 3 to 4, you can predict the outcome at 24 to 48 hours. So if you see a lot of burst, you can kind of predict this will be a good outcome. If it's very less burst, this is a poor outcome. Move on to the next clinical application, which is seizure detection and the effects of medication, if it's working or not. Again, you know that the seizure burden in the NICU is very, very high, more than anywhere else. And you can read all these papers. And you know that seizures are dangerous for the brain. So this is how you identify seizures in the AEG. You look at the lower border and you can see it's going up here, and that's a seizure. Again here, that's a seizure. So this is 4 hours, and you can see 2 seizures here. And remember, you should always click there and look at the raw data, because this could also be an artifact. So it's very important to always look at the raw EEG data to make sure that this really is a seizure. Here you can see in 4 hours, there's 1, 2, 3, 4, 5, 6, 7 seizures. So with the AEG, it's quite useful because even non-EEG personnel can identify the seizures. And this is status epilepticus. We call it the sawtooth pattern. So this is a nice example that I got from Dr. Judy Bingo Zhao. So you can see this child has really high amplitude seizures, and then medication was given, and then the seizures stopped. You could also add other trends, like, for example, the spectrogram or the envelope to reconfirm what you're looking at. So very helpful. So this is an interesting case study. If you look at this pattern here, I want you all to think, what kind of pattern is this before we start the poll. So have a good look, and then Laurie, can you bring up the poll? So what is this pattern? Is it continuous normal voltage, discontinuous, burst suppression? Okay, I can see majority of you have chosen seizures. Discontinuous pattern. Okay. Okay, majority says it's seizure, which is correct. So if you look at this, so what you're seeing here actually is this patient had clinical seizures. You can see it's quite long duration. And they gave some medication. It stopped, but for a very little bit. Seizures started again, clinical. Medication given, stopped for a little while, started again, very long duration, high amplitude seizures. Finally, medication worked, and you can see the seizures have stopped. And then maybe 2 hours later, subclinical seizures start. They are shorter duration. So this is the thing that we've seen in the ICU with even if they're babies, infants, or adults, that if you stop the clinical seizures, the seizures do return, but when they return, they're usually subclinical. So if you don't monitor continuously, you're going to miss it. What you also notice about this pattern is that the background activity is actually continuous normal voltage, and there is some cycling. So you know that this is a healthy brain. This patient has a chance of a good outcome. So you will be quite aggressive in treating these seizures because you know this patient will have a good outcome. So the AEG gives you so much information on how you would like to manage the patient. Like to share some case studies from Japan, from the pediatric neurologists, neonatologists, and you can see we're typical Asians when we take pictures. They are from, they have been very kind to share data and to spread this technique and help doctors around Asia, and I really am very thankful to them for teaching me so much. Okay, so let's go on to the next case study. This is a full-term baby, and look at this pattern. What do you think this pattern is? Is it continuous, discontinuous, burst suppression, low voltage, or seizure? Laurie, can you bring up the poll? Oh. Lovely. Majority of you are getting it right. Awesome. Okay, so yes, it is continuous normal voltage pattern, and you're all becoming expert at this. And this is really a lovely pattern with sleep-wake cycling, and you can see this is a full-term baby, so this is normal for the baby's gestational age. Okay, the next one, look at this pattern. And remember, this is a 26-week gestational age. What kind of pattern is this? Okay, Laurie, bring up the poll. Not bad. Okay, thank you. So all of you got it right, majority of you. This is a discontinuous normal voltage pattern, and the reason is this is a 26 weeks gestational age, and so it is normal for this gestational age. So yeah, you all are getting to be experts at this. Okay, another one. This is a full-term baby with what pattern is this? Laurie? Awesome. Okay, so majority of you got it right. It is the birth suppression pattern. And it is not normal because this is a full-term baby. And you can actually see even here a very short duration seizure. So it's totally abnormal for gestational age. Another one. What pattern is this? This is a preterm baby. Okay, Laurie? Okay, thank you. Yeah, I think nearly there's some of you went between burst suppression, low voltage, and seizure. So it's a tough one. It is flat. And whenever you see a flat pattern, you really have to look at the raw EEG data because it's very funny when there's no activity in the brain. The electrodes just pick up all these artifacts and you keep seeing it looks like kind of a burst suppression, but actually it's just a flat pattern. And this is a preterm with this sort of pattern. It's very predictive of periventricular leukomalacia, so bad outcome. Another one. This is an 8-day-old baby. Look at this pattern. What do you think this is? Laurie? I think this is an easy one. Everyone is getting it. Okay, awesome. So majority of you have got it. Yeah, it's seizures, status epilepticus. So this is a baby with severe brain malformation and with non-convulsive status epilepticus. So you can see that even with this short training session, you can recognize the pattern, but you also can see that it is so important that you look at the raw EEG data because you can never be too sure with all the patterns. So a combination will make it very, very accurate. I'd like to share this research or a publication that was done by Dr. Fang Luo from the Children's Hospital in Zhejiang Hospital. So they have done an evaluation of cerebral function in high-risk term infants by using a scoring system that they have designed based on AEG. So if you want this paper, let me know. It was published in Translational Pediatrics in 2014. So what they did was they looked at a broader group of patients. Some have hypoglycemia, some have acute bacterial meningoencephalitis, hyperbilirubinemia, inborn error of metabolism, etc. And this was their scoring system, and these are for term infants at risk of neurological sequelae. And so their scoring system is based on the AEG background pattern, and this is their numbering for that. Epileptic activity, again, their numbering, and the sleep-wake cycling. So their conclusion on their scoring is that after evaluating a few babies, that if the score is equal or less than 4, it's a normal outcome. Between 4 to 8, it's abnormal outcomes, and more than 8, it was bad. So this is quite a nice scoring system to use on your sick infants. This is interesting data. This is an infant with acute bilirubin encephalopathy. Look at this AEG and let me know what you think of this pattern. Laurie? Yes, majority of you, yeah, correct. Okay, so most of you said continuous normal voltage pattern. And I would agree if I eyeball this, I'll say, yes, you can see some nice sleep-wake cycling. Wow, good outcome. But if you look at the raw EG, and of course I didn't have all the data, there was just a lot of seizures. So because of their scoring system, the total score was 6. And if you remember, 4 to 6 is abnormal outcomes. So yeah, so this infant did have an abnormal outcome. So using both the AEG and the raw data really helps you. I'll end the neonatal presentation with this last case study because I love this. It's from my mentors, Ingmar Rosen and Lena Hellström-Westers. So this is a severely ill preterm infant, gestational age 31 weeks with bilateral intraventricular hemorrhage type 3. And you can see this was done many years ago, so the old paper and pen type. You can see this is a birth suppression pattern and then status epilepticus, and then the baby had a cardiac arrest and loss of all brain activity and something here. And then status epilepticus appearing on a low voltage background and then a birth suppression background. So phenobarbital was given. You can see it has no effect. There's still status, so they gave diazepam. And remember, all this was non-convulsive. And diazepam did stop the seizure, also stopped the brain activity. It's flat, and then seizures you can see appearing again. And so they gave diazepam again, and the seizures finally stopped. Surfactant was given, which decreased brain activity for a little bit, and then, yeah, no more seizures. So if you evaluate this child at this time, you will say that this baby has a high risk for neurological handicap. But on day 4, this is what they saw. And remember, this baby is 31 weeks plus 4 days. So 31 plus 4, this pattern is correct for that gestational age. And there is sleep-wake cycling. So we assume that this will have a normal outcome, this baby. And sure enough, a few days later, the baby recovered clinically and then was discharged and sent home. And then 9 years later, they followed up, healthy baby. And yeah, so this is a really nice study. And this is the reason why neonatologists have this passion to monitor the brain. You talk to any of them, they really care for their babies and want a good outcome. They all want to do continuous EEG. So it's wonderful to be able to have EEG to help them. We move on to the adult ICU. So my journey here was a bit more rocky and difficult because the adult site has so many different types of ICUs, and there were not too many publications on the use of trending in the ICU. So there were more papers in the US. So We went to the US and met a lot of key neurologists in this field who were very kind and helpful. And these are some of the books that you can read, especially this one by Dr. Suzette LaRoche, who was very kind when I visited her, gave me a lot of insights into trending. But I found it really difficult to implement this technique back in Asia because, as mentioned, we do not have enough EEG experts who can do continuous EEG with real-time EEG interpretation. So I had to journey back to Lund with the dear Prof. Ingmar Rosen, and he introduced me to Dr. Hans Friberg, who is a critical care doctor as well as the head of the emergency department. And they were doing a trial using continuous AEG to predict outcomes in hypothermia-treated cardiac arrest patients. And you can read this paper, which was published in 2010. So if you look at cardiac arrest patients, you can see that if the patients die in the first 2 days, the main cause of death is cardiac causes. But if they live on, the main cause of death is neurological cause. So we really should be focusing on the brain to give these patients a chance of a good outcome. So therapeutic hypothermia, or now they're doing targeted temperature management between 32 to 36 degrees. So for adults, the cooling is done for only 24 hours. And this has shown to improve neurological outcomes. So these patients have very high incidence of status epilepticus, from 27 to 44%. So early prognostication is very important because you have to make appropriate treatment decisions and also how you counsel the family. So how can AEG help with this? So we followed their design study, where immediately after cardiac arrest, they will bring the patient to the ER and start cooling the patient as soon as possible, but 24 hours. And then gradual rewarming. It takes about 8 hours to rewarm until they get to normothermia. And then 72 hours later, they do a prognostic evaluation using AEG, median nerve, SCPs, brain MRI, and biochemical markers like NSE. So they start continuous EEG or AEG monitoring immediately and throughout the patient's stay. They use 6 subdermal needles for F3P3, FOP4, and for the adult patients, since the EEG is more simple compared to neonates, there are 3 main patterns that you look at. You just look at continuous, low voltage, and burst suppression. That's it. And of course, the seizures. In adults, the continuous normal voltage pattern hovers around between 5 to 25 microvolts. There's not too much of cycling compared to neonates, which is very easy to see because, because of the babies sleep more and also the patterns of the EEG. So remember only these 3 patterns: continuous normal voltage, low voltage, burst suppression, and then the seizures. So they notice that if they see a continuous normal voltage pattern very early on in these patients, all of these, nearly more than 85% of these patients recovered. If they see a suppression burst pattern, none of these patients woke up. And again, very early on, if they see a flat pattern, it's wait and see because some of these patients may recover. So you keep monitoring closer to normothermia, and usually the flat pattern is there because of the hypothermia. And some of these patients during normothermia, their pattern will start recovering and become continuous. And if they do, then these patients recover. And also during normothermia, that's the time also when you see a lot of status. And if you see it at that time, none of these patients recovered. But if you see status epilepticus later on, then you should look at from which background did the status come. If the status came from a suppression burst background, these patients did not recover. But if they came from a continuous normal voltage pattern, these are the patients that have a high chance of recovery. So these are the patients that should be treated aggressively because they have a chance of a good outcome. So the treatment strategy in Lund is that, of course, you monitor them continuously with EEG, you aim to suppress their seizures, and in selected cases, cases where the status comes from a continuous pattern, where there's preserved SSEP N20 potentials and low NSE, that's neuron-specific enolase, these are the patients you treat aggressively. You will go with thiopental or phenobarbital, and it could take days or even weeks, so you need a lot of patients, but these are the patients that would have a chance of a good outcome. So you can see that the AEG is very useful in guiding the treatment strategy and in predicting outcomes. So I found out from them that there's a group in South Korea at St. Mary's Hospital that's also doing similar clinical trials. So I went to learn from them as well. And you can read their paper which was published in 2013. And you can see that their survival rate in their hospital is also very high, 23.2%, as compared to even the Seattle group, which is doing the same thing. Right? So very interesting. So we took, this is a nice case study. And you see this pattern quite often in these post-cardiac arrest syndrome patients. Look closely at this patient, look at the pattern, and then let me know what pattern you think this is. Laurie? Okay. So majority of you said it's continuous normal voltage pattern. Thank you. Yep. If I looked at only the AEG, that's exactly what I would think. And pretty high voltage one at that. But when they looked at the raw data, it was seizures. And then you're wondering, where is that seizure pattern? Where's the sawtooth activity? The reason is most of these patients, when the seizures start, they don't stop. They'll go on for hours or even days. So that's why it's just the lower border just lifts up and it just stays that way. So it's very important that you look at the raw data. You should check it to make sure that there's no seizures as well. I'd like to share some case studies from Professor Hitoshi Kobata. He's the director of the Osaka Mishima Emergency Critical Care Center in Japan. He's also a neurosurgeon, and he performs the neurosurgery. He's in charge of the ICU. He also does the AEG, so he's a really amazing person. Taught me so much and so willing to share his data. So I'm very thankful to him. So here are some of his case studies that he has shared. So this patient is a 27-year-old male, cardiac arrest. And you can see the AEG here, very obviously, very flat. And there was no evolution, no matter how long they monitored. So the patient had a bad outcome, and he remained in coma and died 3 days later. Sad. This is a 26-year-old female, cardiac arrest. And you can see here the status epilepticus. And she was in non-convulsive seizures. So she remained in coma, and she was discharged in persistent vegetative state. This is an 86-year-old male patient, again with cardiac arrest. This patient was treated with targeted temperature management at 34 degrees centigrade. Initial AEG was flat, and then there were occasional suppression burst pattern. So he did not regain consciousness and died 2 days later. So very obvious with the AEG. This is an interesting one, 51-year-old male with a pontine hemorrhage. So obviously you would suspect raised intracranial pressure, and you can see the blood pressure is quite high. This patient was in alpha coma, and then somewhere here you'll see that amplitudes are dropping and becomes low voltage, and then just flattening out. But when you look at his vital signs, the blood pressure was still maintained, and so the doctors were kind of surprised. Is something wrong with the AEG? And they were trying to figure it out because the vital signs still did not have any changes. But 2 hours later, the blood pressure fell, and then shortly after that, the patient went into cardiac arrest. So this was useful to know that the brain showed changes much more early. This is a very interesting case. A 46-year-old male with subarachnoid hemorrhage, grade 5. And if you look at the grading, grade 5 is in coma with a Glasgow coma scale GCS3, and you can see that means it's very severe. The patient arrived in coma due to ruptured right ventricular artery dissecting aneurysm. This is a terrible thing to happen. Usually poor outcomes with this sort of thing. So they did the AEG anyway, and they saw it was a continuous normal voltage pattern. So they decided to go ahead and do a coil embolization. So this is, you can see, during embolization, there was a re-rupture, and you can see the extravasation of contrast media on angiogram. But they managed to embolize it and complete it. And but the patient, both his pupils were still dilated. So when the patient returned to the ICU, they continued with the AEG, and it was a flat pattern. And so TTM was initiated at 34 degrees centigrade, and his AEG gradually started evolving and becoming a continuous pattern. Unfortunately, I don't have a screenshot of that because that was hours later. So usually there is very little chance of recovery in a VA dissecting aneurysm. But because of the AEG, they decided, to go ahead with the coil embolization. And also seeing the recovery in the AEG, they knew that this patient had a good chance of recovery. And sure enough, the patient recovered without neurological deficits. This is another interesting patient, 57-year-old woman with subarachnoid hemorrhage. Again, Glasgow coma scale is 3, which is severe. But the patient had a reactive pupil. So if you see the brain CT, you can see that there's subarachnoid hemorrhage. And the CT angiogram, you can see aneurysm at the bifurcation of the right middle cerebral artery. So usually the SAH guidelines says that you have to monitor and observe these patients, but these patients are intubated and sedated. to prevent the risk of rupture of the aneurysm. So how do you know what's going on in the brain? So luckily they had the AEG machine and they started monitoring, and this is what they saw. And the AEG showing burst suppression pattern. So this may help them make a decision not to have any surgical intervention, but to just continue monitoring. And we did try using the spectral edge frequency as well to see if we can learn anything from it, but we couldn't. So we relied on the AEG and the raw data. And when they did the MRI, DWI, you can see that there's diffuse cortical ischemic change and brain death. So really, the AEG really helped in making a decision not to give any treatment, and the MRI anyway helped in confirming the prediction of brain death. And this patient remained in coma and died on the 9th day. This is another case, 84-year-old female with subarachnoid hemorrhage, WFNS grade 5, GCS3, reactive pupil. And again, you'll see that the CT angio shows aneurysm, and no neurosurgeon would operate on a patient at this age and with a GCS3, but her pupils were reactive. And they had the EEG machine, so they decided to monitor anyway, and they saw that she had a continuous pattern. So they were wondering, is there a possibility of a surgical intervention? So they discussed with the family. They said, normally we would not, but what do you want to do? So they decided, okay, let's do MRI, DWI to see. And they were looking for some ictal infarction, but surprisingly, there were only subtle ischemic changes and no whole brain ischemia, despite the fact that there was diffuse SAH. So with the consent from the family, they went ahead and did a surgical clipping of the right MCA aneurysm. And here you can see the changes after operation. There was just minimal ischemic change. And this patient recovered back to her previous condition, which was moderate disability with clear in consciousness. Modified Rankin scale is 3. So really the AEG was very helpful in helping make this treatment decision. So the conclusion from this experience is that can AEG be used for prognostication of the poorest grade SAH patients? Because these patients are always so difficult to know what to do. So we are waiting for the publication. Hopefully it will be approved and get released. Meanwhile, there are other groups in Asia that are doing clinical trials, and we are waiting for their publications so that we'll be able to share more knowledge. So we look at other trends. I will show you a few clinical applications. So if we look at the frequency analysis, Marco has already given you a detailed explanation of the frequency trends, and you can learn a lot about them from this atlas of intensive care quantitative EEG, nearly 500 pages of QEEG samples you can learn from. So I would ask you to read this. So there's spectrogram, band power, power ratio, spectral entropy, and the frequency trends are useful to identify frequency shifts that may be related to sleep-wake stages, anesthesia, metabolic patterns, seizures, and asymmetries, etc. Unfortunately, we do not have much experience in Asia with these frequency trends, as they do require more channels for monitoring, and the data should be relatively artifact-free. So this is very difficult to do if it's only the ICU staff doing the monitoring. But we try to run those trends together with the AEG to see what we can find out from them, and hopefully we can find out a lot of interesting information. The nice thing with those frequency trends is if you're using the synopsis, you can create detection thresholds, and in ICU, it's very hard to know the baseline of the patient because every patient is so different, and the baseline of the patient may also change from day to day. So being able to set the threshold very easily is very important, and that's what you can do here. And anything that crosses the threshold will raise an alert to alert the nurses and ICU staff. So it's very, very helpful. And even if electrodes fall off and things like that, and other various alerts come on. So as mentioned, these frequency trends are very useful for ischemia detection. If you look at the cerebral blood flow, the normal is between 35 to 70. And if it does decrease, you will see changes in the EEG within 5 minutes. And until 12 to 18 ml, the changes are still reversible. I mean, the neuronal injury. Once it goes down to 8 to 10, with EEG, there's suppression of all frequency. This is when there's neuronal death. So really, the EEG gives you a window in which you can intervene to potentially prevent permanent brain injury. And this is becoming very important because we have thrombolytics and endovascular therapies which have been shown to be very effective in acute stroke and vasospasm treatment, especially when you do it very early. So the EEG is very useful for that. So one of the trends, this is by Dr. Paul Vespa from UCLA, been to his ICU, awesome. He came up with a relative alpha variability trend, or RAV, very useful in detecting ischemia by trending the changes in the fast frequencies. It's often used in SAH, or subarachnoid hemorrhage patients, to detect when the vasospasm will occur, because you don't want vasospasm to set in, and so you need to detect it as soon as possible. And again, sometimes it's hard to even see it on the raw EEG. So what you do with the relative alpha variability is you take the ratio of the relative alpha power, which is 6 to 14 hertz, to the total power, which is 1 to 20 hertz. And then you look at the variability over 8 hours. So you're looking at the peak and trough, and if it's very variable, this is normal. When it's not, it's quite flat, this is ischemia. This is the visual scale for grading of the relative alpha variability. We usually just hang this along on the bedside for the nurses to eyeball. This is excellent, good, fair, poor. And we usually would trend this with a bigger long window, like 8 to 12 hours window, because if vasospasm sets in, it will set in a few days later. So you can look at a compressed data. So this is a nice data file from Dr. Suzette Laroche. This patient has a right ACA aneurysm, so you can see here in this area that the variability is quite low compared to the other parts of the brain. But somewhere around here, you can see that all the regions of the brain are affected. The variability is decreasing, but clinically there's no change in the patient. And then 5 hours later here, the patient had clinical deterioration confused, bilateral leg weakness. And so combining with the clinical presentation and looking at this, they decided to rush the patient to angiogram, and they gave intra-arterial nicardipine. And now you can see the relative alpha variability is nice. It has come back. And if you compare this and this, it is so much better. So this patient had no permanent neurological deficits. So quite a nice trend to help with that. Another trend is the alpha delta ratio. This is by Dr. Jan Klassen from Columbia University. Again, visited them. They're really very good at what they're doing. So with this, you take the ratio of the alpha power, 8 to 13 hertz, to the delta power, 1 to 4 hertz. Again, very useful in ischemia monitoring and detecting vasospasm in subarachnoid hemorrhage patients. So if you look at this patient data, this patient before vasospasm, you can see moderately variable. And then during vasospasm, it's quite flat, and they must have done some intervention. And you can see now after the intervention, now the variability is good. So having a continuous method of monitoring for vasospasm is critical so that you can intervene at the right time. This is another data from Dr. Suzette Laroche, and you can see these are different channels in the EEG, and you can see it's quite variable until it's starting to go down until somewhere at 11:30, it's really flattened out. So all the ADR has dropped, and then at 13 hours, the patient was given some pressors to increase the blood pressure. There was some slight recovery, but it wasn't sustained, and it just remained flat. So the outcome is not good. The next frequency trend is the spectral entropy trend. Now, this trend has been found to be highly correlated to the depth of anesthesia. And if you attend any ICU conference, you will hear them always talking about sedation, because it's a majority of ICU patients receive sedation. And if you under sedate them, it's not good. If you over sedate them, you know, both contribute to consequences that can negatively impact both clinically and financially. So the spectral entropy works similar to the BIS monitor, but they found that it is more reliable. And you know that the BIS monitor, or they call it the bispectral index, is widely used in most ICUs, and especially in the operating room. It does work really well in the operating room because patients are relatively neurologically normal, but in the ICU, it's a bit difficult because these patients may have neurological damage. So what you're looking for is numbers. So as long as the number is between 40 to 60, you know that the patient is well sedated. If you see the number going above 60, you know the patient is waking up. If it's going below 40, you know the patient is going too deep into anesthesia. So the right number to keep the patient on is somewhere between 40 to 60. So this is really easy for the intensivists because all they're looking at is a number to titrate their sedation. So this is just an example of how you can look at it. So here you see the patient is awake, and you can see the number is 87. And so we just put on the AEG trend as well, and you can see, yep, awake. And I tried using spectrogram trend as well, and you can see some, not too sure really, the activity. And then when the patient was sedated, you can see just mildly sedated, just below 60. And you can see the AEG showing that pattern very obviously. And if you look at the raw data as well, you can see the burst suppression pattern. So combining these numbers maybe with the AEG and the raw data, you can have quite a good idea of the sedation level of the patient, because sometimes these numbers may not be reliable, especially when there's artifacts and all that. But having a few other trends together and the raw data will really help you make that conclusion. So in conclusion, EEG logi, the rule number one, the raw EEG signal is always the truth. So you have to rely on that. And rule number two, the AEG and other trends are very useful complements. It has helped many intensivists in better management of their patients. And so in conclusion, the Neurocritical Care Society was formed in 2002 with Dr. Thomas Black as the founding president. You can see him here. And this society is dedicated in improving the neurological outcomes of patients in the ICU. And the first, or you can say the neurocritical care as a specialty was accepted in 2006. And the first exam was in 2007. So quite a young society. So in Japan, in 2014, the Japan NCS, they formed an affiliation with the NCS in the US, and that's why you see this picture. In 2015, Japan revised its guidelines for neuroresuscitation to include continuous EEG and AEG monitoring as a standard of care. Other countries in Asia have also joined the Neurocritical Care Society, and you can see here, this is the Neurocritical Care Society in the Philippines, and you can see Dr. Gretchen Brophy, who's the current president, and Dr. Stefan Mayer, the past president. And these doctors are all very key in trying to promote better neurological outcomes in the patients. So the members, the NCS members, are usually intensivists, neurosurgeons, critical care nurses, and a few neurologists. So we're hoping to get more neurologists to join the NCS because and neurotechnicians, as this expertise is really, really required to support ICU monitoring in Asia. With them joining this, it would really help in really very good EEG monitoring of these patients and really affect the outcomes. So we still have a long, long way to go. There's also a great need still for better electrode applications and for other trending patterns for the ICU. And we hope that with the combined efforts of all these doctors and technicians and nurses that we will learn a lot more. So in conclusion, I would like to say that the EEG trends have made continuous EEG monitoring of critical care patients feasible in Asia. This allows for more accurate decisions on patient management, which leads to better neurological outcomes. So, and we've also seen that it has decreased the length of stay of patients in the ICU. So if you consider the brain a vital organ, then it should be monitored like any vital sign in the ICU. So I would like to encourage all of you to have this passion to monitor the brain of these patients, these critical patients that need it the most. Yeah, I'd like to end with acknowledging my mentors who have helped me so much through this journey. And I'm sure a lot of you will have questions or maybe want some of the papers. Please do not hesitate to send me an email, anitak@cadwell.com. Thank you.
Thanks, Anita. This is Alex. I just wanted to, there was one question posed in here. I think you have time for a question. And the question is, in many centers, raw EEG data is not done simultaneously as there is no provision in the AEEG to do it. How do we resolve this?
That's a good question. That's a tough one, really. I hope you can get a device that will provide you with the raw data as well. Because as you saw with my slides, I wish I could show you more, showing how you could really misdiagnose the patterns without the raw data. So you do need raw data. And we do teach the intensivists and the nurses just very basic EEG, what an artifact looks like, what an ECG would look like, eye movements, EMG artifacts, simple things like that, and what a seizure would look like. And so, yeah, I'm sorry, but I think you do need a proper system that has raw EEG data. But if you don't, I guess you just have to go with the AEG then.
Thanks, Anita. That was really it for outstanding questions. Everybody else, there were a lot of comments just about how well you did and exceptional information and appreciation for your insight.
Oh, thank you very much. And I hope all of you will carry this passion to help these patients. And especially I see in the attendee list that majority of you have the expertise. So it's really good to get involved in this and with your expertise.
Okay, with that, I guess we'll close this session out. Just a reminder to all the attendees, asset CEUs will be applied to you for attending this session. Look for an email from Cadwell later today or tomorrow with information on how to access the recordings of this session and the other previous two sessions, the previous 2 Wednesdays of this month, because those will be made available on our website. And again, we'd like to thank you so much for attending, and we hope that you enjoyed the webinar series and learned a lot. And please feel free to email our presenters, AnitaK@cadwell.com or MarcoM@cadwell.com for questions specifically about their presentations. If you have any other educational related questions, please contact workshops@cadwell.com. And thanks again, and thank you, Anita and Alex, for your assistance, and Anita, your expertise. Signing off. Have a good
Thank you. Stay safe, everyone. Take care.